morning, everyone. I'm Bill Mueller from here in Chicago. Welcome to our next session called My Best Medical Retina Case. Welcome to Chicago, first of all, and thanks to the organizers once again for allowing us to present these cases. I've got just a couple of introductory slides, which hopefully are in the system, introducing our speakers. If I can get my slides up, that would be awesome. But I want to say that we ask these individuals to present. Here we go. Thank you. So first of all, going back to the start here, welcome to Chicago. I personally have no financial disclosures. Our speakers will indicate their disclosures at the time of their presentations. I want to welcome Fernando, Arevalo, Courtney, Crawford, Mark Pennesi, Amy Schefler, Matt Cunningham, and Russell Van Gelder presenting cases from around the country. We asked them to basically prepare a case that's kind of an unknown, but it will have an answer. So we want the cases to be presented. None of the panelists have seen these cases. We all present them as mystery cases to each other, hopefully stimulate some discussion. The cases are going to be challenging, but yet not too terribly esoteric, so you hopefully have some take-home messages as far as learning something from these various cases. So we all get challenged with our cases. Our first presenter will be Dr. Fernando Arevalo from Baltimore, Maryland. Fernando.
Thanks a lot, Bill, and I'd like to thank the organizers for the opportunity to present a case, and I'd like to acknowledge my former Retina fellow from Argentina, Andres Lasabe. These are my financial disclosures. So this is a 76-year-old male with bilateral visual loss for about 7 days, and there is no history of previous ocular disease. The visual acuity in the right eye was 2100. In the left eye, the visual acuity is 2060. The slit lamp examination was unremarkable. The IOP was normal in both eyes, and you can see on the pseudocolor photographs that there is significant opacities in the vitreous cavity, vitreous cells and haze in both eyes. The infrared of the spectralis allowed us to see these preretinal perivascular deposits that you can see here on the arrows, and we call it preretinal inflammatory precipitates, and these are overlying the retinal blood vessels. Some more images with the infrared. And on the structural OCT, they look like stalagmite-like preretinal inflammatory deposits that have been previously described, and, but very rarely in only a couple of case reports. And you can see here the characteristics of these stalagmite-like preretinal deposits only in the right eye. This is the fovea of the right eye. The left eye had no deposits. And I want to stop here and like to hear from the STEAM panel about a possible diagnosis.
So Fernando, some of the best stalagmites I've seen have been in Carlsbad Caverns in New Mexico, but that was supposed to be a joke.
People are laughing, so it's good.
No, I think you have to think of infectious, inflammatory, even a few tumor processes here. And I'm sure there's something going on here, obviously, with, you said there was inflammatory cell.
Anybody else? Any ideas?
The patient is elderly and there's no injection or pain, you said, right? So
No injections.
Right.
No,
So, I mean,
no history of injections.
I mean, PVRL until you're sure otherwise.
Inserted differential, absolutely.
So definitely we thought about infectious etiologies, and we ordered all the infectious workup. But 3 days later, he comes back with these lesions in the periphery, inferonasal, and we can see the necrotizing retinitis unilaterally. The OCT of that area shows thinning of the retina, and fluorescein angiogram shows some late hyperfluorescence in that area of retinitis. Within the workup, we did an AC paracentesis with PCR to try to rule out viral diseases, toxo, and it was positive for varicella zoster virus. So this is a case of ARN in the right eye and bilateral vitritis. We treated with oral valacyclovir, an oral prednisone, 48 hours after starting antiviral therapy. After 2 weeks of follow-up, you can see significant reduction on the vitreous opacities and improvement on the necrotizing retinitis lesion. The inflammatory deposits have decreased, as you see on the infrared on your right. And here is the arrows showing that have decreased significantly. This is again at 2 weeks. Another aspect, and the fovea also has improved significantly. But at 3 months, they have disappeared completely here on the infrared again, and the area of necrotizing retinitis has healed at 3 months. So in summary, this is a bilateral vitritis case that improved significantly at 6 months with unilateral arm in the right eye. Also at 6 months of follow-up, we can see significant healing with the treatment of antivirals combined with steroids 48 hours after starting the antivirals. And to conclude, stalagmite-like deposits are a clinical sign that is often overlooked, although it's rare. A sign of preretinal deposits predict or is suggestive of an active state of disease. We think that probably suggests an inflammatory condition, most likely infectious, ocular toxos, syphilis, acute retinal necrosis, and endogenous fungal endophthalmitis, more than a non-infectious condition. And let me go if this goes a little more. And PCR with anterior chamber paracentesis, I think, is key to make the diagnosis. And despite that this is a rare condition, I think that we should, if you have cases, put cases together and study this better. Thank you very much for your kind attention.
Fernando, thank you. Just one concluding comment, not to, if you tune into the NUTSI rounds, which is once a month, there was a wonderful case presented by the Duke group this past Monday night on a cryptococcal case that looked just like your case. Once again, a fungal infection causing this. So we've seen this with acute retinal necrosis. We've seen this with other cancer diagnoses, but in general, the spots melt away when the patient's appropriately treated.
Yeah, there is a report on intraocular lymphoma as well.
Right.
Yeah.
Randall, thank you.
Thank you.
Onward to Courtney. Courtney has case number 2. We're going to ask our timer just to give us 5 minutes per presenter rather than 3 and 3. 5, please. Great, thank you.
All right, everybody. Welcome to the best session of AAO weekend. Cool medical retina cases, I like to call it. So anyway, my name is Courtney Crawford. I'm excited to share my case, so let's begin. Here are my financial disclosures. So, interesting case. I have a 16-year-old, really intelligent young lady who did her research, thank you, Dr. Google, and found us saying that, hey, Doc, I have decreased vision and increased metamorphopsia. And she said, Doc, I have metamorphopsia. You do? So her vision is totally normal. Her pressures are normal. Anterior segment exams are normal. Her right eye fundus is what you would expect, pristine for a 16-year-old girl. Her left eye, wait, when you're looking in the slit lamp, so she has this yellowish choroidal lesion with overlying RPE pigment changes and subretinal fluid along the inferior macula. Fluorescein at 54 minutes and 9 minutes does show an early patchy hyperfluorescence and late staining. ICG shows early and late hypofluorescence. And indeed, on OCT, she does have a sliver of subretinal fluid. And then finally, the clencher, her ultrasound does show high reflectivity and then shadowing beyond the lesion.
So comments from our, well, I was going to say comments from our panelists, but I guess you have the differential right there.
Sorry, can we go back?
Too late.
Too
Looks
late?
like a
Too late.
choroidal osteoma. Looks like a choroidal osteoma.
Oh, really? Does it
Yes.
really? Oh, does it really? Okay.
Now we can talk about management. How's that? Okay.
So yeah, I mean, yeah, that's this list. Sorry, guys. Probably the closest in identifying a sclerochoroidal calcification, but that's superior temporal. Hemangiomas, we know what that looked like, but we don't want to miss the amelanotic melanoma, right, which has a low reflectivity, right? So,
But still, your ultrasound wouldn't really be compatible with that.
true, that is true. So we decided in the 16-year-old girl, we weren't going to treat at 1 month and 2 months, and at 3 months, you know, you walk into the exam room and she is not happy. She says, "Doc, my metamorphopsia is worse." Okay, so her vision is 20/40, and she does have increased subretinal fluid, new intraretinal hemorrhage. And so I don't know if you can see, but along the inferior aspect of the macula, there's actually new subretinal hemorrhage. And this is the early and late fluorescein, which shows a late leakage pattern consistent with, and then an OCTA consistent with choroidal neovascular membrane, right? So the cat is out of the bag. I apologize, you guys. But choroidal osteoma with choroidal neovascular membrane is not something other than AMI that we see very frequently, right? So maybe we could shift our focus to how we manage this disease. And so a few comments. We do expect interval growth over 41% over a 10-year period. Decalcification can occur. But really, what are we looking for? We're looking for the vision change, just like in our patient, due to choroidal neovascular membrane. So what about the choroidal neovascular membrane? If it's subfoveal, the only treatment that I can identify is probably anti-VEGF, which we did in this young lady over 2 treatments. And extrafoveal, you might do PDT, you might do laser, you might do anti-VEGF. Finally, let's go back to her follow-up after 2 anti-VEGF injections. Vision went from 20/40 to 20/30 to 20/25. She's happy again. You walk into the room, "Doc, my metamorphopsia is gone, and all the subretinal fluid and hemorrhage has resolved. I see her every 3 to 4 months. Choroidal neovascular membrane is not returned. And most importantly, she left a 5-star Google review."
Any comments from the panel?
So I have patients like this, and we published a series with Ahmad Mansour years ago with anti-PGF and patients with choroidal osteoma, and they respond well. They have the need of less number of injections than other etiologies, and I think they do well. This is a treatment of choice. PDT to me is a little worrisome because it decalcifies the lesion and you can lose vision. But you well said that would be for extrafoveal membranes and not foveal lesions.
Be careful, though, with PDT because the intent sometimes is to decalcify the lesion so it stops its growth, but you can induce inflammation. We actually induce neovascularization with PDT, so just be cautious. I agree.
That's right.
Other quick comments?
That's right. The only other comment I would say is that sometimes once they become very decalcified and the RP is really incompetent, they can end up with this very passive accumulation of fluid, and that sometimes doesn't respond as well to the injections as an acute CNV.
All right, Courtney, we'll hope for a 5-star review for you. All right, thanks, Courtney. Appreciate it. Next is Mark Pennesi with our third presentation. Mark? And give Mark slides up. Perfect. Thank you.
All right. Thank you. So you might recall back in April, we had an eclipse that passed through North Texas. And so this patient was a 23-year-old male who came in and he said, right after the eclipse, he started noticing a paracentral scotoma. And he also was having photophobia. He denied any nyctalopia or problems with dark adaptation, and no other findings on review of systems. He had no family history of any genetic eye diseases. And on exam, his vision was 20/20. His anterior segment exam was unremarkable.
Hey, Mark, just a quick question. You said that he noticed it after the eclipse. Was he actually gazing at the eclipse?
So he did look at the eclipse, but he said he wore protective eyewear the entire time. But he was very worried that he had done something.
Okay.
So here is fundus photos from him that were unremarkable. If you look at the autofluorescence, you can see some very subtle changes in the fovea, and I'll magnify that with just a small area of hypo and hyper autofluorescence. On visual fields, he did have a small pericentral scotoma in the right eye. And here is the OCT, and I'll just kind of pause here and say, does anyone think this looks like solar retinopathy?
No.
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 So this OCT was quite curious, and you can see that there is some areas of what appear possibly to be schisis, but then there's also these hyper-reflective columns in the outer nuclear layer, which was also quite unusual. We did an ERG on him, and his rod responses were essentially in the normal range. The cone responses were right at the borderline. So this was not really consistent with something like X-linked retinoschisis, but we did think about that as a possibility. So I'll stop there and see if anyone has any ideas.
Comments from our panel?
So the images on the structural OCT that look like hand-led fibers are sign that could have some deposits in there. I don't know if it's typical of any inherited retinal disease, but I would vote that that's probably what is going on because Mark Pennesi is presenting.
I would say you could think about a early cone dystrophy, although the vision was really good, but based on the ERG with a mild.
But the patient's also very young, so it still could be good.
Yeah, no, I think those are good thoughts. So I'm going to tell you the answer. So we did genetic testing, and he came back with two variants in CRB1. One was a known pathogenic mutation. The other was a variant of unknown significance. But this is not the typical appearance of most patients with CRB1. Most patients with CRB1, or at least with biallelic mutations, present with a labor congenital amaurosis with a very thick retina, loss of laminations on the OCT. But it turns out that this particular mutation is interesting. So if you have a deletion within a certain portion of the gene, it disrupts one of the isoforms of CRB1, which is exclusively expressed in the Mueller cells rather than the photoreceptors. And this has actually been reported before, where you can see schisis and also these hyper-reflective columns in the outer nuclear layer, as you can see in the bottom right here. So this turns out to be a case of CRB1 maculopathy, and I say maculopathy because the full field ERG was close to normal. So I think the takeaway from this is when you see schisis, don't just think about X-linked retinoschisis, also think about CRB1 as a mimicker, especially if you have a female with schisis. Thank you.
Mark, quick question. In the world of fantastic genetic testing, how essential is electrophysiology?
Yeah, so I get this question
All the time.
all the time. I do not think ERG is dead yet. It still has prognostic value. And I'd remind you, even with genetic testing, only 70% of the time do we solve the case. So we're not up to 100%.
Mark, one other question on that. When you have a case with a known pathogenic mutation and a variant of unknown significance, do you need to phase those? Do you need to figure out which parent those came from?
Yes, so we are getting segregation for this. We haven't done that yet.
Mark, thank you very much. Onward to Amy Schefler. Amy.
All right, thank you so much to the organizing committee for the opportunity to present. Excited to share this case with you all. Here are my disclosures. This was a 75-year-old patient who was sent to me by an outside retina specialist for long-standing mildly blurry vision and retinal findings by history for a while. His past medical history had a history of treated prostate cancer, which had initially local lymph node metastases, but had had surgery, radiation, and was on androgen blockers and doing well with a low PSA. And had supposedly cutaneous melanoma, which was locally resected 30 years ago with no mets, and some other medical conditions that were not relevant. His family history was relevant. His father had had male breast cancer, rare as everyone knows, and both of his brothers had had prostate cancer. And he was on a variety of medications, none of which are relevant to the case, and notably had no history of use of pentosan, defroxamine, and other medications that we worry about with retinal side effects. So here's the fundus photograph of the right eye. His vision was actually pretty excellent, 20/30 -2, and we can see this orange-yellow kind of amorphous subretinal material along the superior arcade and then trickling downward into this meniscus-like configuration along the inferior arcade and a little bit of atrophy temporally. Pretty similar picture in the left eye, also with quite good vision. On the OCT, we can see these nerve sensory detachments with this kind of polymorphous material. The ERM is pretty intact, the ellipsoid zone is pretty intact, but he's got a good amount of this deposition here. And then a scan through this area of meniscus shows this subretinal material. Here's the fundus autofluorescence, and as we expect with vitelliform-like lesions, these are certainly hyperautofluorescent. On the FA, they are hypofluorescent early and late. This material in the subretinal space is really only mildly hyperfluorescent, and on the ICG, completely hypocyanescent throughout. So just to help out with the construct of the differential diagnosis, when we think about vitelliform disease, these are sort of our broad categories that we think about. Genetic diseases, of course, BVMD, tractional causes, toxic causes, degenerative causes, including certainly pachychoroid disease spectrum, and then paraneoplastic causes. What other testing?
Well, the one thing that certainly comes to mind is the cutaneous melanoma past, but
That's right.
there's no acute history more recently,
right.
30 years ago.
That's right. That's right. So given the nature of what I do, as well as this patient's history, I was super concerned about a paraneoplastic cause, and in particular about acute exudative polymorphous paraneoplastic vitelliform maculopathy. So we ran an autoantibody panel, both the CARA panel and the MARA panel, and the patient came back positive for quite a good number of these, some of which are associated with prostate cancer, some of which are associated with breast cancer, some of which are associated with cutaneous melanoma, in particular with MAR. But the interesting thing was that when we did this patient's ERG, both full field and multifocal ERG, it was really on both the photopic and the scotopic testing completely normal, with just a very mildly attenuated signal in the fovea on the multifocal. So really, this patient did not look like a typical picture for CAR or MAR. So thinking, okay, this looks like it's more of a vitelliform paraneoplastic picture. We did a PET CT as well as a CT chest abdomen pelvis. The patient had absolutely no new primaries. We did a full breast cancer familial sequencing panel because the patient had actually never been tested for that. Every single one of these known genes for familial breast cancer was negative, and the patient underwent multiple full body scan exams, which were totally negative. So we threw the kitchen sink at this patient because there's really no established treatment for this. We gave him oral steroids. We tried plasmapheresis, as you would for more of a CAR more type patient. We even tried PDT, thinking about a pachychoroid type component, and absolutely nothing helped the patient. But he didn't get worse either. He felt that he was really pretty much had no subjective change, so we're continuing to observe him closely. And it's been over 2 years. This is what he looks like now, still with excellent vision, still with these subretinal deposits, but hanging on tight. So essentially, this is a 75-year-old guy with probably an unrecognized genetic family cancer syndrome who had this very remote history of cutaneous melanoma and stable treated prostate cancer, but with APPVM that did not progress and no new primary cancer recognized.
Do you find any treatment consistently beneficial for this?
You mean among other patients?
Yes.
Patients often do not do well with this condition, unfortunately, most of the time because they have a primary cancer that is newly diagnosed or actively progressing. The reality is that most of them don't have a long survival. Certainly in the land of cutaneous melanoma and all of the incredible immunotherapies we have now, there are more patients surviving longer and longer. But these patients in general do much worse than the ones who have the idiopathic form of the disease.
And how much faith do you put in the CAR and MAR panels?
I mean, as everyone knows, and others on the panel could speak to this better than I, these autoantibodies are very nonspecific. There are a lot of retinal diseases that give us very heterogeneous pictures. But in this type of case, it was helpful.
Other comments, please.
Yeah, except anti-recovering.
That's right.
So the one that is quite specific is the 23
More so.
kD anti-recovering.
For sure.
Amy, great case. We appreciate it. Thank you.
My pleasure.
Onward to Matthew Cunningham. Matthew is the site from Orlando, the site of Academy next year. So in addition to being here this year, come back next year to Orlando.
Thank you to the organizing committee for allowing me to present this case. These are my disclosures, none which are relevant to this talk. So we have a 40-year-old Puerto Rican female who was referred for possible CSR. She declares a 5-week history of decreased vision, right greater than the left, denies any pain or any recent trauma, and of note had a normal eye exam at an outside clinic 6 months ago. She has a history of hypothyroidism, depression, and breast cancer, which was diagnosed in 2022. She underwent chemotherapy until October of 2022 and bilateral mastectomies in November. Her medications that she can recall are as presented. She was uncorrected 2350 in the right eye and 2040 in the left eye. Anterior segments in the IOP were normal. No APD was noted and no vitreous cells were noted. Her fundus photographs are as shown and were pretty unremarkable. But on fundus autofluorescence, you can see some abnormal hyperautofluorescent streaks in the right eye. And on spectral domain OCT, there was some subretinal fluid, some corrugation of the RP layer, and maybe a little bit of thickened choroid. RNFL showed that there was some elevation of her optic nerve heads in both eyes, right greater than left. And her fluorescein angiogram demonstrated staining of both optic nerve heads. So I'd like to ask the panel, is there any thoughts for a 40-year-old with a history of breast cancer, with optic staining, optic edema, subretinal fluid, maybe a thickened choroid?
Panel?
B-scan? Right.
Yeah, we'll get there.
Neuroimaging.
CT.
Okay, CT, okay. So obviously this is a pretty broad differential. So we thought about non-infectious etiologies, we thought about infectious neuroretinitis, syphilis, Bartonella, Lyme, tuberculosis, thought about CSR, even idiopathic intracranial hypertension, or could this be toxic related?
Remind us what current medications are.
So the ones that she could remember were related to hypothyroidism and depression.
Okay.
So we started her conservatively on Pred Forte 4 times a day. We ordered uveitis labs. We also called the oncologist, and we actually were informed that their office sent the patient urgently to the ER for an MRI and lumbar puncture, which were within normal limits. But there's always more to the story, right? So the oncologist also reviewed the list of chemotherapy agents, and notably the patient was receiving pembrolizumab or Keytruda.
PD1.
So 2 weeks later, she came in, count fingers in the right eye and 2400 in the left eye. You could see worsening subretinal fluid in the right eye and new subretinal fluid in the left eye. Her fundus photographs have changed, and there's these nummular, discrete yellowish deposits in both eyes. And you can see the autofluorescence now. She has these hyper-autofluorescent lobular areas consistent with subretinal fluid, especially in her left eye. So uveitis work came back completely negative, so the diagnosis was compatible with ocular complications secondary to pembrolizumab. We initiated prednisone 40 milligrams, and after a discussion with the oncologist, we discontinued pembrolizumab. 1 week after oral steroids, you could see subretinal fluid was improving. She states vision's not as dark, so we continued the prednisone. 5 weeks later, subretinal fluid was completely resolved, so we began a 30-20-10 initiation of a taper. And 4 weeks later, she was 20/20 and 20/25 after a refraction with complete resolution of the subretinal fluid off of prednisone and prednisolone. And these were her final images, and you could still see that there are some abnormalities in her fundus autofluorescence with those hyper-autofluorescent streaks. So checkpoint inhibitors induce activation of T cells against cancer cells by actively blocking inhibitory receptors. There are multiple checkpoint inhibitors, and these are classified by the ligand by which it targets. However, this targeting can also result in excessive immunity against our normal organs. One of the landmark papers was actually done out of Wills with the Shields that actually goes into the ocular complications that can occur. And you can see here that in our patient, we saw a VKH-like syndrome as well as an optic neuritis picture, but it could affect any portion of the eye. According to the American Society of Clinical Oncology guidelines, if a patient comes in with 2200 or worse vision, they're permanently discontinued from checkpoint inhibitors. They should be urgently referred to ophthalmologists, and systemic corticosteroids and maybe even ocular or intraocular steroids should be initiated. So some key take-home points: immune checkpoint blockades can result in uveitis. Onset's typically within the first few weeks to months, but actually can occur even after discontinuation. Treatment involves immunosuppression and close communication with the oncologist, and always consider uveitis masquerade, such as metastatic disease or paraneoplastic syndromes.
So great case. About 2 to 3% of patients on checkpoint will have ocular complications. Amy, quick question for you. Would you have stopped the pembrolizumab or try to keep the patient on with the steroids?
Right, yeah, I mean, there's controversy about this situation based on the patient's systemic situation. I almost never do anything without talking to the medical oncologist.
Absolutely. But we find many times we can keep the patient on the medication.
That's
On steroids
That's
as
right.
well. Thank you very much.
Thank you.
Our final case, Russ Van Gelder, who we stole from uveitis meeting next door. Russ, welcome.
I thought I was at a uveitis meeting. All right, well, thank you for the opportunity to present here. I have no financial disclosures. So this is a 39-year-old gentleman originally from Mexico, no prior ocular history, came to an outside ophthalmologist with a few days of redness, photophobia, and pain, and was noted to have a hypopion. He had a workup outside, which was negative for HLA-B27 syphilis, and his toxo IgM was negative. He had a normal chest x-ray, but his quantiferon gold was positive. He was referred to pulmonology. They did serum sputums. They were negative for acid-fast bacilli. He was treated with difluprednate 8 times a day and tapered, and overall his symptoms improved. The local ID service consulted and deferred treatment for what was presumed to be latent TB at that time. 7 months after that initial presentation, he continued to have a red eye and some anterior chamber cell, and so was referred to our practice for further evaluation and management. At that point, his review of systems was positive for chronic cough, but he had no weight loss, shortness of breath, or fevers. Here's his initial exam. He had 20/20 vision, no APD. He had 2+ injection on the right. He had granulomatous appearing keratotic precipitates on the right, 1+ anterior chamber cell and flare, and some very mild anterior vitritis. And you can see his fundus photos were essentially normal at that time. We did do a fluorescein initially. It shows some very mild diffuse leakage on the right. You'll note his OCT shows some very mild diffuse thickening and some visible vitreous cell, particularly on the right. So at that point, our assessment was granulomatous anterior uveitis in the right eye. In the setting of a positive quantiferon gold test, we referred him to our infectious disease service for consideration of treatment for at least latent TB, because given the chronicity of the uveitis, he might require immunomodulation down the line. We put him back on difluprednate at 4 times a day and tapered, and we asked him to come back in a month. Well, after 3 months of stable exam, we tapered him down to once a day on the difluprednate. He had a difficult time coordinating with our ID service, and they did not get him on treatment until his 3rd month, when they started 2-drug therapy for presumed latent TB. In his 4th month after we first saw him, he presented acutely to the emergency room with markedly decreased vision, increased redness and pain. He was hand motions at that time, 4+ anterior chamber cell, 2mm hypopion, and he now has some cell and flare in the left eye. So any thoughts here from the panel?
Comments?
Any ulcers?
Good
in the mouth
question.
or,
No oral
genitals?
ulcers, no genital ulcers. That's an excellent question. When you see hypopion, you have to think about Béchette on that differential.
Other comments?
So at this time, his fundus exam now shows a large serous detachment, or a large detachment on his right, which we judge to be serous. And you can see his autofluorescence also shows some decreased autofluorescence inferiorly on the right in this now hand motion vision. The left eye has a fairly unremarkable exam. Any further thoughts here? So what we ended up looking at was whether this was indeed tubercular. So we did an anterior chamber tap as well as a vitreous biopsy. We ran PCR for mycobacteria specifically, 16S bacterial DNA, 18S fungal, HSV, VZV, and toxoplasma all came back negative. The biopsy on flow showed no abnormal B or T cell populations, although they did note some atypical looking white cells on the cytology. We talked to the ID service and said, well, the PCR was negative, but he's positive with progressive panuveitis. Let's accelerate to 4-drug therapy, which they did. And then we got his biopsy specimen into a research study that we were doing on whole genome sequencing, and we sequenced the full sample, and this ended up showing 4 copies per human genome of Epstein-Barr virus. So we gave him an intravitreal injection for possible EBV-ARN syndrome at that time. 11 days later, he presented to the emergency room with fatigue, cough, and tachypnea. He was admitted. His chest x-ray was normal. His chest CT was normal. However, on the CT, an incidental finding was noted of adrenal masses, which were then confirmed on this MRI, and further exam when he presented showed bilateral testicular lesions with ultrasound consistent. Red is consistent with granulomatous inflammatory lesions. So any other thoughts from the panel here?
Couple
think
things
it's sarcoid?
sound like lymphoma.
So, so sarcoid is on our differential, and a masquerade is now very much on our
Lymphoma.
differential. So our medicine service decided to do a PET scan, which lit up diffusely, including the left maxillary sinus, multiple lymph nodes, sternum, stomach, kidneys, pancreas, multiple organs. And this led to a biopsy because tissue is the issue. And the biopsy showed EBV positivity in the adrenal gland, inferior turbinate, and ethmoid sinus, along with CD56 staining, which is natural killer T cell specific stain. So our diagnosis here is an ocular NK T cell lymphoma that was masquerading essentially as tubercular uveitis. This is an uncommon T cell lymphoma. It's driven by EBV positivity. There were only 4 cases previously in the literature. All were positive for CD56 and EBV, which is sort of the hallmark. This is the first case that we're aware of where the initial diagnostic clue actually came from the ocular biopsy, and it's something to be aware of. But I think the teaching point here is that diagnosing tubercular uveitis in a patient from an endemic area is very challenging because of the high basal quant gold rate, and you have to continue to have suspicion for other etiologies.
Russ, great case. I want to thank our 6 panelists. I think wonderful presentations, hopefully some take-home messages and points. So that concludes the session. But thanks, guys. Appreciate it.